Guys, today we are going to discuss about primary sclerosing cholangitis. As the word means itis, there is inflammation and obliterative fibrosis of extrahepatic and large intrahepatic ducts and dilation of preserved segments. Occurrences between median age is 30 to 50 years. Male predominance is seen. Male to female ratio is 2:1. Coming to pathogenesis, it is an autoimmune disease, so there will be circulating antibodies and T cells in the periductal stroma and associated with HLA-B8 and some other major histocompatibility antigens and ulcerative colitis. So it is an immunologically mediated process. Environmental factors will be there and genetic factors will be there. They trigger the inflammatory injury to the bile ducts. First degree relatives are at high risk, and T cells activated in the damaged mucosa of patients with ulcerative colitis. They will go on migrate to the liver as they are cross-linking antigens which are present on the bile ducts. Okay, infections in the intestine, they leads to alterations in the cholangiocytes which incites the inflammatory injury. Atypical perinuclear antineutrophilic cytosolic antibodies, which is PANCA, they are present against the nuclear envelope protein, which is found in 65% of patients with primary sclerosing cholangitis. Coming to morphology, large intrahepatic bile ducts and extrahepatic bile ducts, they will show they are involved and they show epithelial injury and neutrophilic infiltrates. They are superimposed on chronic inflammation. Edema and inflammation are seen, which leads to narrowing of the lumen, which is leading to fibrosis and stricture formations. Stone formation is seen in dilated ducts. Inflammatory injury, so one characteristic pattern is onion skin appearance, onion skin fibrosis, as there is a periductal fibrosis or sclerosis. And increasingly it will lead to atrophic ductal lumen, leading to obliteration and scarring. The scar referred to as tombstone scar. Smaller intrahepatic bile ducts are also involved, but there is no direct involvement. Due to cholestasis, there will be mild injury and prominent ductal reaction will be seen in small intrahepatic bile ducts. So this will lead to cholestasis and fibrosis, which further leads to biliary cirrhosis. Biliary intraepithelial neoplasia in further develops into cholangiocarcinoma, which is a prominent feature seen in PSC. So coming to clinical features, fatigue, pruritus and jaundice, half of the patients will be asymptomatic, but it is not in case of ulcerative colitis patients because they will undergo regular screening. So they will easily find out this PSC. And the prominent feature is serum rise in alkaline phosphatase. So ascending cholangitis is the initial presentation. Chronic pancreatitis and chronic cholecystitis will be seen as there is involvement of pancreatic ducts and gallbladder. Fibrosis and cirrhosis will occur eventually. Gold standard for diagnosis of PSC is beading. Beading in the large intrahepatic and extrahepatic biliary trees by endoscopic or magnetic retrograde cholangiopancreatography. So irregular biliary strictures and dilations will be seen. Inflammatory bowel disease patients and ulcerative colitic patients are majorly prone to this PSC. 8% of inflammatory bowel disease patients, they will develop primary sclerosing cholangitis. Okay, in case of IBD, there will be involvement of small bile ducts only. Okay, it can be seen in endoscopy or by magnetic retrograde cholangiopancreatography. Small duct PSC, it progresses into typically large duct PSC. Classical primary sclerosing cholangitis distinguished from the cholangitis. IgG4 sclerosing disease will be due to steroid it is responsive to steroids, and it is associated with pancreatitis. 5 to 10% of cases autoimmune hepatitis along with the PSC will be seen. Cirrhosis over 10 to 15 years. Cholangiocarcinoma, 20% of cases. So cholestyramine, which is a bile acid sequestering resin. It is a treatment, and endoscopic dilatation or stenting, liver transplantation, which is the ultimate for end stage liver disease patients. So we'll summarize with the differences between PBC and PSC. Primary biliary cholangitis, the age of the patient will be 50 years. PSC, the median age is 30 years. In PBC, female predominance is seen, whereas in PSC, male predominance is seen. Georgians, thyroid and scleroderma are the disease associated with the PBC, whereas ulcerative colitis and Crohn's are associated with the PSC. 95% of cases antimitochondrial antigens are positive in case of PBC, and antinuclear antigens are positive in case of PBC, whereas in PSC antimitochondrial antigens are negative, means absent, whereas antinuclear cytosolic antigens are present, and antinuclear antigens are present. So radiology, PBC is normal, whereas in primary sclerosing cholangitis there will be bleeding and strictures of large bile ducts and pruning of the small ducts. Whereas duct lesions or florid duct lesions, loss of small ducts in case of PBC, inflammatory destruction of extrahepatic and large intrahepatic ducts, fibrotic alteration, obliteration, and medium and smaller hepatic ducts, ductular reaction of smaller portal tracts. Thank you guys. Thank you.